First, taking the opportunity to thank the organizers for the kind invitation to come and to share with you some thoughts about a subject who is still, I think, in some part of the world, a matter of debate. In my country, this idea to assist HIV positive patients in their child wish has been actively debated in the 90s. And if it was debated in the 90s because it is in these years that major change in the life expectancy and quality of life of these patients occurred with the introduction, of course, of the three therapies that everybody is aware of, with a dramatic change in death rates that drives the population of patients living with the virus and living with the virus in good condition to increase dramatically. Until 85, 86, nearly all patients were dying in a few years. And you see that with the introduction of the drugs in the 90s, slowly but then regularly, the death rate has decreased. And of course, the cohort of patients living with the virus has at the same time increased because the people were not dying anymore. As you see this age and sex distribution in Belgium, we have a quite similar number of male and female, and they are in their reproductive ages. So at the moment, the disease has become a chronic disease with long life expectancy in young patients. The question of quality of life and of children has become a major issue. The reason why we decided to help these patients was because we considered that we had enough data to show that we could do it safely. We had quite good information, of course, about the sexual transmission of HIV. And what was important for us is that there are good notions that the reproductive secretions compartment could be different of the compartment in blood, and that we could not extrapolate from the results of the blood results what would be the situation in semen or in vaginal secretion. The second major reason is that the treatments were decreasing dramatically the presence of the virus in these secretions, and that we had some technical means to clean the sperm, as we said already at that time. I will come back to that. That's for male positive patients. For the female, of course, you know that the risk is mainly during the birth process and can be dramatically reduced by the drugs and the cesarean section at that time. Today, the efficacy of the drugs may make most of the time the C-section unnecessary and certainly not recommended. But the combination of these two approaches at that time made the residual risk for the child to be infected low enough to consider that we could intervene in these patients also. Ethically speaking, there was obviously no right to oppose reproductive desire of these patients, but the discussion was to helping them or not. No collaboration was considered at that time the strongest message about the pregnancy risks, but assisting these patients was a way to minimize the risk, to avoid unprotected intercourse risk, and to avoid the patient to leave the structure feeling to be ununderstood about something very important for them, and then decrease adhesion to treatment. So at the end of the 90s, we began to treat a few patients and were quite enthusiastic with the result and published a paper in the early years of 2000 to defend and explain the combination of medical knowledge and ethical thoughts to open the assistance to this patient. We try to be as rigorous as possible, taking a lot of people on board to have a multidisciplinary competences. We train the staff. We had quite some tension with our art staff at the beginning of the program. Today they would be impossible for them to stop to treat this patient and to make continuous evaluation. Why did we took this precaution? Because there are data in the literature that it's taking some risk. Contamination is described for most of the blood-borne viruses. Cross-contamination has been demonstrated, has been reported in art, and there are at least 2 contaminations with not well-performed insemination processes with HIV-positive men, one in the USA in the early 90s, and one more recently in Japan. Just to remind you that everybody is focusing on HIV, but the most contaminous virus is from far the hepatitis B virus, for which there are many data, especially in the transfusion model, to show that the risk of cross-contamination is much more higher than for HIV. So we began with a separate lab. We are at the end of the 90s when we designed that. We also adapt a lot of things inside of the lab to give the personnel, the staff, feeling of security. There has been a lot of discussion between universal precautions, saying that anyway, any patient can be infected at one time, so you have to apply your rules to everybody, which is certainly true. But nevertheless, after nearly now 15 years of experience, I would say that having a separate route of managing the sample is extremely comfortable for everybody. Comfortable for the patients, comfortable for the staff, comfortable for the other patients, and probably safer at the end of the road. At the beginning, we thought it would be the interest of a few, but of course it was not the case, and slowly but regularly the number of new patients knocking the door was increasing in the early years after 2000, when we announced publicly that we were hosting this patient, and in 2005 we stopped counting. Big work has been to be done to wash the sperm, not because of the washing procedure, because of the detection of the residual potential virus structures after processing. Semen is not easy for HIV detection. There are some inhibitor of the PCR process, and of course we wanted to have a very low level of detection, much lower than what is used by the infectiologists to follow their patient in blood. The process by itself is a classical discontinuous gradient. All this has been published in a paper in Fertility and Sterility. What's interesting is that you see on that graph that when the patient has some significant level of viral load in blood, the procedure becomes regularly unable to drive you to undetectable viral load in the final preparation. And that is certainly the reason why the Japanese cases occurred. It was a patient with a very high level of viral load in blood, and they didn't test the final preparation, which was, in that case, obviously contaminant as the woman was infected. There is no large experience. This is a schema from a few years from now, showing a number of results of groups in Europe, mainly using intrauterine insemination for male HIV patients with more than 1,000 children with no reported seroconversion, neither in the partner, neither in the newborn child. Nevertheless, none of these work has been done in a randomized setting, and I think that all of the groups, including ours, will assume that, but that's the reason why it is until now still not recognized by the Cochrane as evidence-based, what I would agree of, even if there are very few doubt about its efficacy. The use of IVF or ICSI for these male patients could be introduced mainly in two ways. First, because you need it for the infertility situation. You have a male with altered sperm count, and that's the way we used it. We didn't use, and I think nearly nobody in Europe except a French French first randomized trial was comparing ICSI and IUI. For the rest, ICSI and IVF was used when necessary for fertility reasons and not to decrease the risk of transmission. It was not the same in the US, where the CDC was not endorsing IUI, and a certain number of groups was using ICSI in the only way to increase the safety level. We developed and published even a procedure to be able to use testicular sperm, so very, very low counts, by a simple method in which you transfer the semen from one drop, and then you, throw the liquid away, take fresh liquid, take your sperm again, do the same in a second drop, and so on. We made an experimental design with 1 million viral particles per milliliter, and show that in 3 washing the level becomes undetectable, making possible to treat even azoospermic men. A lot of publication in that group with normal, I would say, pregnancy rates, also more than 1,000 couple and cycles with no reported seroconversion until now. Now the discussion is opened to even stop to use these techniques for normal fertile couples and to go to timed intercourse with or without additional drugs, but of course this go out of my subject, so I will not enter this very interesting discussion that maybe some of you has followed in a more general way, because it is now a matter of debate to increase the number of patients treated, not to protect protect them from the evolution of the sickness, but to decrease the risk of contaminating others. Medication becoming a way to fight against the epidemic that in a way is probably more effective than the condom. But this is maybe a little out of the subject. If we go now to the female patients carrying the virus, there is, of course, a very easy way to obtain a pregnancy without having risk for the partner is to do vaginal insemination. Auto-insemination in a normal fertile couple will be enough to obtain a pregnancy, of course. But there are many publications who show that this population is of much higher risk than the general population to combine the viral carrier with infertility because there are cross-risk between the two diseases. So we have and we had a lot of women in our center because of infertility reasons and carrying HIV. In this population, there are some questions who are still not fully resolved today. Do these patients have a decreased ovarian reserve in comparison to normal, usual infertility patients? The data are conflicting, and the question is certainly not fully solved. We asked this question as early as 2004 in a review paper in Human Reproduction Update, and still then there are a lot of dispute around that question. The second one is the potential effect of some of the drugs on the mitochondria of the oocyte and an eventual decrease in oocyte quality, not by the sickness, but by the treatments the patient has to follow. Also, number are less extended. We have a large experience in HIV positive women, and the pregnancy rate is reasonable, but seems to be lower than what we would expect regarding the age of the patients. We tried, but it's extremely difficult in a retrospective way to compare these patients to our general IVF population, and it just shows what we observed in the daily work, is that the stimulation is much more difficult, and even in a multivariate analysis, the doses of gonadotropin used by patients, this patient is higher than the general population, with less oocyte collected, and the less, of course, fertilized egg, less embryo transfer, less pregnancy per embryo transfer, and less deliveries per cycle. But in the multivariate analysis, they disappear in front of the two first one. Nevertheless, you see that the pregnancy per initiated cycle and the delivery per transfer is quite lower than in the compared population. This could be confounding reasons. These patients are different in many ways, but the observation is clear. Most of these patients, you know, come from sub-Saharan country or South Asia, and these are regions in which another disease is quite prevalent, which is sickle cell anemia. And so to finish with a nice positive story, I would like to share with you the story of a couple coming from sub-Saharan Africa to our Center for Male Infertility. And we discovered that the lady was HIV positive when we make the workup of the patient. She was severely immunodepressed. The immunologist tell me one day that this patient would have been dead within a year if she was not coming to have a child and to discover a situation. In addition to the HIV situation, they were both carrier of sickle cell anemia, which is not something exceptional in these regions. They were very, it's a nice memory for me. This couple was very nice couple. They faced the situation. They shared the situation of the HIV positivity. The patient took treatment. Of course, it has become the priority, and the reproductive wish was put aside. And nearly 1 year later, they come back and they ask, with a very good recovery of the situation in the lady, to take again the reason why they came to us and to go on with the fertility treatment. And so we were facing for the first time to, at the same time, treating an infertile patient, an HIV positive patient, and a sickle cell anemia couple, which is not easy. You know that in PGD, collect a large number of eggs is a major factor of success, and this patient has a quite not so good response to ovarian stimulation. Her first cycle was eventually cancelled because we considered that the response was not good enough to proceed. And at the third cycle, the second one was successful in terms of going up to the end of the procedure, but failed at implantation. And at the third attempt, she was pregnant and delivered an unaffected and uninfected child. So this shows that slowly but regularly the stigmatization and the discrimination in access to health care for this patient is disappearing, and today it's a common practice in our center. Of course, not in all centers, and I don't think that all centers has to be equipped and learn to manage these patients, but it's, in my view, extremely important for their quality of life, but also for the fight against discrimination, that they find places where they can be normally treated and hosted like any sick patient looking for help in constructing a family. It's a big work, and I could not finish without making some reference to all the groups who were involved, especially the reference laboratory for AIDS and the immunodeficiency treatment unit, the doctors who are spending each month 2 or 3 hours with us in multidisciplinary meeting, reviewing each individual file of each patient to discuss the treatments and the indication, and of course the virology lab who put a lot of energy to adapt the procedure of detection of HIV to our needs. The National Fund for Scientific Research have financed a lot of this work, and we had some unconditional grants from Nidacon and Merck to do this work. And these patients are patients from which we learned a lot. And I thank you for your attention.